Sir, Stavros, wait.
It's okay, I'll go next.
Yeah, I missed one talk, so shall we change the order?
Okay. So, thank you, Chairman. Ladies and gentlemen, it's my great honor to talk about the POEM procedure. So, I hope most of you are watching the yesterday's live demonstration from the Metropolitan Hospital. So, this is our clinical data. So, 15 minutes. So, I will quickly review our experience. So far we performed the procedure more than 600 cases in our hospital. So procedure detail is equal to the original procedure. So that was reported in 2010. At the middle part of the esophagus, we create the submucosal tunnel that lasting more than 10 centimeter, and then distal end is beyond the G junction. After creating submucosal working space, we cut the muscle layer. And the most important point of the procedure is to totally dissect the lower esophageal sphincter. And then after confirmation of the hemostasis, we close the mucosal entry using clips. So procedure is like this. First injection in the middle part of the esophagus, saline with a blue dye, indigo carmine, and then put the 2 centimeter longitudinal incision using cutting current. And then after mucosal incision, we get in a submucosal space. Top half of the image, you can see a surface of the muscle layer, and then bottom half of the image, you can see submucosal fibers. And then at the dissection of the submucosal tunnel, we are sticking to the surface of the muscle layer. And then we continue the creating submucosal tunnel very close to G junction. Submucosal space totally changed to a narrow space, even though we carefully follow the surface of the muscle layer. And then, so this is the very good case. We can see the palisade vessel at the distal end of the esophagus very well. So this is the end of the palisade vessel. We watched the palisade vessel from the submucosal layer, and then behind we can see a white space. That is a gastric side. And then we can also recognize the spindle vein vasculature like this, the vascular rich area in a gastric cavity. And then after creating submucosal working space, we start cut the muscle. So we are trying to preserve the longitudinal muscle layer. So like this. So circular muscle layer, we are cutting, and then behind it we can recognize the longitudinal muscle layer. Even achalasia patient, longitudinal muscle layer is very thin. So even when we try to preserve the longitudinal muscle layer, so it finally it split each other, but we are trying to do it. And this is the gastric side. So in an anterior myotomy, we can see lesser omentum. And then this is the muscle layer and the submucosal layer. This is the end of the tunnel. This is a puncture of the injection needle. This is the muscle layer, and the perforating artery is here. So in the POEM procedure, this is a very simple but very important indicator. Before procedure, junction is tight, like this. After procedure, the junction is totally relaxed, like this. So we can confirm at the end of the procedure, the patient can eat the food the next day good. So after confirmation of that hemostasis, we close the mucosal entry using crypts. Okay. So this is what I mentioned. Even when we try to preserve the longitudinal muscle layer, so that is a very fragile, and then split each other. And then, for example, this is the pericardium, so that we can see it very well in a submucosal endoscope. So this is another case. This is the end of the myotomy. Restal omentum, we can see some fat tissue. And then this is the diaphragm. And then sometimes we can see anterior vagus nerve, like this. So barium swallow before and after procedures like this, dramatically improved. And then in the case of vigorous achalasia, we put a longer myotomy, so abnormal contraction also gone. Okay. So in order to perform this procedure, CO2 insufflation through endoscope is the most important. It's, when we use a CO2 insufflator, it's totally equal to thoracoscopic or laparoscopic surgery. So first case was done in 6 years ago. And then so far, we did more than 600 cases. So youngest is a 3-year-old, and senior patient is an 89-year-old. So our indication of the POM procedure is all the achalasia cases and the other, including other esophageal motility disorders, diffuse spasm, Nutcracker, jackhammer, hypertensive areas, everything involved in this application. So previous treatment is various. So some patient receives the balloon dilation, Botox injection, and some of them receives a previous surgery and the recurrence of the disease. So success rate is, fortunately, is good. So Eckert score 1 and 2 is 95%, and improving the points, 3 points, more than 3 points involving that, so 97%. So far, we have no experience of a major complication, so just the minor complications. So fasting period, elongated, extended, and then naturally the problem solved. So symptom score, Eckert score improvement is like this. And then this is, I think, a very good fact. This is a subjective evaluation of the procedure. So patient satisfaction rate, subjectively, 10 point is a full score, and then most of the patient mentioned that the 8.5 or something. So good results, I think. So this is a case of type 2 achalasia, Chicago classification with some compression of the esophageal body. And then after myotomy, so barium passage improved very well. This is a case of with a spasm. So this patient complain also chest pain, so we have to put a longer myotomy. Sometimes we put the more than 20 centimeter myotomy. So not so like this, so very well improved. So POM procedure, we don't add the anti-reflux procedure. So everybody concerned about the POM GERD. But actually, in my series, only 5% of the 5% of all cases, just 5% receives a PPI. So I will skip this a little bit. This is the first case in the ASIN 2 years ago. So our youngest case is a 3-year-old, And then this is a volume swallow before and after procedure, very smooth passage. But 3-year-old is too small, too compact. So this is a limitation of the indication. So this is the most severe case of achalasia. So right chest is most of them are replaced by the dilated esophagus, and we can also see a lot of food impaction in the dilated esophagus. So in those cases, so before performing endoscopy, we request the patient to throw up all the esophageal content by him or by herself by drinking a lot of water. And then after that, we perform endoscopy. So in this case, after treatment, what I mean is the patient throw up the esophageal content, so like this, shrink a little bit. And then, so like this, so very dilated esophagus case, so identification of a GE junction is very difficult in a submucosal space. So in this case, we use 2 scopes. One nasogastric scope was in a retroflex view from the stomach, and then now we can check the right from the submucosal endoscope. So this suggests, this confirms the tip of the endoscope already reached to the gastric cardia. So this is a volume swallow of the same case. So this case, this is 7 days after treatment. So he can eat C can eat food, regular food, 7 days after treatment, and then discharge from the hospital. Eckhart score improved 6 to 1, so very, very good recovery of the symptom. So this is the last movie of my talk. So patient who receives a previous Hera myotomy, we put the greater curve myotomy. So you can see a mucosal bleb in a gastric fornix. And then in a submucosal endoscope, we can identify the His angle, muscle of His. We can identify here. And then when we cut the muscle like this, we cut the whole His angle muscle. And then, I'm sorry. Okay. So circular muscle has already been dissected, and then behind it, this is a longitudinal muscle already split each other. And then so behind it, we can identify diaphragm. So this is a mucosa, backside of the mucosa. Mucosal fornix is here. Now we turn endoscopy to the fornix side. Then we can confirm the myotomy has completed. LES, in this case, LES is totally dissected. We can confirm it. Before, after procedure, G junction widely open. Eckhart score again improved very well. So another indication is a diffuse spasm, but the time limitation I will skip. Okay, so finally, I really appreciate a kind invitation to John and F. Callisto.
Thank you, Dr. Inoue. We'll discuss the paper later on.